Professor Claire Roger tonight. Claire is director of her intensive care unit at the University Hospital Nimes, and so I would like to offer her the opportunity to speak before Ben Rogers, who actually has a pre-recorded presentation, and so I'm sure that he won't mind. It's wonderful to see Claire. She's been a visitor to Australia and is a very good friend to many of us here, and she has wonderful expertise in PKPD, and that was her PhD topic a few years ago now, and obviously has wonderful clinical expertise too. So we're really looking forward to her presentation on treatment for intermediate resistant organisms. Thank you, Professor Roger.
Thank you very much, Jason, for this kind invitations and it's a great honor to be part of this fantastic webinar. And in the next 10 to 15 minutes, we'll focus on a quite challenging situation in the clinical practice, the treatment of intermediate resistant microorganisms. So can you see my screen?
Yes, thank you.
Yes. Okay, so here are my disclosures. So first of all, I would like to go back to the definition of minimal inhibitory concentration. And as you know, MIC is the concentration that prevents visible growth on a standardized medium after a standardized time and temperature and with a standardized inoculum. So MIC is not a concentration that can be directly compared to any in vivo concentrations that we could observe during treatment. This is a measurement of the activity of an antibiotic against microorganisms using an international conventions of MIC dilutions theories based on, as you know, a twofold dilutions. And these measurements will exhibit some degree of intra-laboratory and also inter-laboratory variability, as well as some differences between strains. So this variability will be an issue when we'll try to use MIC for defining our PKPD targets, as we'll see in the next slides. So, as I mentioned, MIC and susceptibility testing is one component to adjust drug dosing for infections, but these infections, of course, occur in a body from a host with immune systems, and of course, we can't just rely on this index. So, some clinical breakpoints have been set to separate strains with MICs for which the therapy has a high probability of therapeutic success. So the category of susceptible pathogens. On the opposite, the resistant pathogens will have a high probability of therapeutic failure using standard dosing. But these clinical breakpoints will take into account the drug concentrations observed and the dosing. We have a third category, which are the intermediate pathogens, for which the probability of therapeutic success can be high when higher dosing are used, and will make the assumptions that higher dosing could achieve adequate PKPD target against higher MICs, as you can observe on this graph. So this is the assumption that intermediate pathogens could be successfully treated with higher than standard dosing. And that's the reason why we moved from the UCAS definitions of clinically intermediate microorganisms that was defined as microorganism associated with uncertain therapeutic effects, and that could have successful treatment when the drugs were physically concentrated at the site of infections or when a higher dosage were used, and we moved from these definitions to the definition of susceptible increased exposure. More recently, this category defines microorganisms where there is a high likelihood of therapeutic success because exposure to the agent is increased by adjusting the dosing regimens or by its concentration at the site of infection, and that's mainly for urinary infections. And exposure is increased by different options, and this will take into account the mode of administration of the antibiotic, the dose, of course, and the dosing interval. So if we look now at, as an example, the UCAS MIC distributions for the couple meropenem and Pseudomonas aeruginosa. So you can see on these MIC distributions, on one hand, the epidemiological cutoff will separate wild type from non-wild type strains. And you can see the clinical breakpoints here of 2 and 8 milligrams per liter. And there's several questions. The first questions, but that's not the topic today, is should we use similar dosing for all these strains? And the second question is, which dosing should we use for these intermediate microorganisms? Because as you all know, minimum inhibitory concentrations is one of the major determinants of the PK/PD targets, whatever the antibiotic considered. For concentrations dependent antibiotics, it's the maximal concentrations above the MIC. For the therapeutic PK/PD targets, whereas for time dependent antibiotic, it's the time the concentrations remains above this MIC. So MIC is a determinant of PK/PD targets, but do the PK/PD targets change when we are treating pathogens with increasing MICs? In this pre-clinical infection model, looking at ESBL and non-ESBL strains, you can see here that the relationships was not modified for ESBL for microorganisms with higher MICs. So the relationships is the same, but of course, higher MIC will be more challenging to target and to achieve PK/PD target. As you can see on this graph, with low MIC, the time, the concentrations remain above the MIC is quite long. And with increasing MIC, this will definitely reduce this time and make the achievement of PK/PD target much, much more difficult. So the second question is, as we've seen, the MIC is one of the major determinants, but can we adjust drug dosing on this value? And in this very interesting paper, Johan Mutten suggests that we should not rely only on one MIC value to adjust drug dosing, but raise it to consider a safety margin. And if we look here in 2 different situations, on the left panel, you can see when resistance is quite rare, considering the ECOF as the MIC target is acceptable. But on the right panel, you can see here, you have the wild type strains in blank. Then the strip area represents MICs with low level resistance phenotype. And for the black areas, you have the MICs with a high level resistance phenotype. And when resistance is quite common, then we suggest to use safety margins of twofold dilutions to take into account the variability observed between an intra-laboratory. So we need to use the safety margins, and we need, as we've seen just previously, to use probably different mode of administrations to achieve PK/PD target for beta-lactams. As I've shown you previously, when you consider a low MIC, it's quite easy with intermittent bolus infusions to maintain the concentrations for a longer period of time. But when it's targeting higher MICs, you can see that with intermittent bolus, this time is highly reduced. And then you need to consider alternative administration mode for beta-lactams. And you have represented here the use of extended infusions or continuous infusions with a loading dose to maintain the concentrations for the entire dosing interval above this high MIC. Here's as an example, an MIC of 8 milligram per liter. So if we look in clinical data, now you can see in this study conducted in 27 from the team of Lodis, studying Pseudomonas aeruginosa infections and different dosing strategies for piperacillin tazobactam. And you can see here that the probability to achieve the PK/PD target, that was here 50% of the time above the MIC, is achievable with intermittent bolus infusions of 13 minutes. But when you are targeting much higher MIC for Pseudomonas aeruginosa here, the 16 MIC, you see that only prolonged infusions or continuous infusions can achieve this PK/PD target. Similar results have been published for meropenem, and you can see here different administration mode of meropenem as a bolus infusion of 15 minutes compared to 3-hour prolonged infusions or continuous infusions in plasma and interstitial fluid. And you can see that for the higher MICs here, only the continuous infusions can achieve the PK/PD target of 100% of the time above the MIC. I will not discuss this target as this has been done previously in previous talk. But if you use, just as a reminder, continuous infusions, of course, you need to verify that the drug is stable for this mode of administrations. And for meropenem, we have stability data showing that 8-hour infusions is acceptable for clinical practice. Do we have now clinical data showing that this mode of administrations can improve our patient outcomes? We have some retrospective studies here showing that for ventilator-associated pneumonia, the clinical success was higher in the continuous infusion group, especially for higher MICs here. So higher clinical success rates, and when we measure the concentrations in the lung, we can also see here comparing 2 different administration modes of ceftazidime in pulmonary infections, same dosing but different administration mode, we can see that we can achieve higher pulmonary concentrations. So that's probably the administration modes to prefer when treating pathogens with high MICs. So of course, we want to achieve this target in plasma. So the target of 100% of the time above the MIC for the sicker patients. But what we really want is to achieve therapeutic concentration in the infected tissue. And you have represented here the concentration in the tissue above the MIC, and also here above the mutant prevention concentrations. And that's the second aim of optimizing drug dosing, is to prevent from regrowth. And you can see here from preclinical data that time above the MIC of 1 will ensure efficacy, but you'll have quickly rigorous at this level of concentrations. Whereas when you target higher concentrations, up to 6 times the MIC here, you will prevent rigorous and have clinical efficacy. Because what we want is to prevent from selecting some of the subpopulations with higher MICs. And you have here the example of different subpopulations, wild-type bacteria. Among these populations, you have some strains with higher MICs. And if the concentrations, the antibiotic concentration at the site of infections is too low, then you will select the resistant strains. So we have a double aim to ensure efficacy, but to prevent emergence of resistance. That's the reason why the PK/PD target for beta-lactam is recommended for the sickest patients as 4 to 8 times the MIC, 100% of the time. And to ensure and to achieve such high PK/PD targets, then you need to use therapeutic drug monitoring. And as an example, we've seen that for intermediate strains for meropenem, it can be to achieve concentrations up to 16 to 32 milligrams per liter. So definitely therapeutic drug monitoring is the only way to ensure that you achieve this PK/PD target. But as we've seen previously, you also need to be very careful with toxicity and neurotoxicity in particular, and patients with strains with high MIC are at risk of toxicity. And above the 8 times the MIC, you may have some encephalopathies that are often underestimated, especially in patients under mechanical ventilations and sedated. So this is safety and toxicity thresholds, and you can refer to this really nice paper in intensive care medicine to look at these toxicity thresholds. Of course, this is a cutoff, and probably you may experience some toxicity above or below this threshold, but that's like a guide to use for a therapeutic drug monitoring in these patients. So this is quite challenging for beta-lactam. That's also challenging for other drugs. And you have here as an example for vancomycin and Staphylococcus aureus. We also know that strains with higher MIC can be very challenging. And in this meta-analysis, we can see higher mortality and a higher failure rate in patients with strain with high MIC. And the standard dosing used will not enable to achieve the PK/PD target, and we'll need to use higher dosing regimens to optimize drug dosing. And we may have to use quite high dosing here as 1 gram every 6 hours. And then, as you know, you can experience nephrotoxicity if you don't monitor drug concentrations. But probably what we need in these populations of patients, it's the use of dosing software to optimize and individualize antibiotic therapy to, of course, ensure efficacy, but also to prevent emergence of resistance. And this dosing software enable to calculate the AUC above the MIC, which is the PK/PD target for vancomycin, and to look at efficacy and toxicity threshold. So that's probably the best way to optimize in these populations. The second approach to consider in these intermediate resistant strains is the use of combination therapy. And when we look in observational studies treating MDR Pseudomonas aeruginosa, we can see that 1/3 of the patients actually received combination therapy, mostly with aminoglycosides or ciprofloxacin. And to optimize in these strains, the combinations therapy, very sophisticated approach using a sophisticated model of hollow fiber model that consists of a PK system that will mimic human plasma concentrations profile and can evaluate the efficacy of this combination therapy. And as you can see here, in very difficult to treat carbapenem and aminoglycoside resistant strains of Pseudomonas aeruginosa, the use of quite high concentrations of imipenem associated with tobramycin could ensure efficacy and also prevent emergence of resistance, which is a main issue in these strains. And again, this means rationalizing the combinations, but also means using quite high and off-label drug dosing. As you can see here, an imipenem 5 gram per day dosing regimens with a 1 gram loading dose associated with quite high tobramycin dosing. So this means, again, to be very careful with toxicity. But sometimes in these very difficult to treat pathogens, you may tolerate this toxicity and try to maximize the efficacy using quite high dose of aminoglycosides and then apply renal replacement therapy to try to minimize toxicity. And you can see here data from an experimental ovine model showing that we can just maintain the trough concentrations below the thresholds with hemodialysis. And we also have some data from humans in ICU patients with the use of TRRT to reduce exposure when treating pathogens with quite high amikacin MIC, as you can see here. And the very high dosing regimens were applied up to 60 milligrams per kilogram. But probably in the next future, what we will need to treat this kind of strains is precision medicine using the interstitial and the tissue concentrations, using data from PK model and integrating rapid diagnostic test and susceptibility testing with a higher precisions to try to adjust and to individualize drug dosing in these patients. Thank you very much for your attention.
Wonderful, thanks, Claire. There is one question for you in the Q&A. I might refer you to that because we are a little bit behind time now. But that was a wonderful presentation. Gives people a really strong idea about what they can do in those challenging scenarios whereby very few antibiotics available, and those which are available to treat an infection may require higher dosing, and what the approach may be for that. So thank you once again, Claire Roger.